So today our focus will be on congestive heart failure. And the aim of this lecture is to give you some practical tips and advice when it comes to identifying and treating congestive heart failure in dogs. I must mention that I am not a cardiologist, but at Dechra we do work with cardiologists to ensure that we can provide practical education for vets. And this webinar has been developed utilising the resources of our cardiologists and the learnings that we have gained from assisting veterinarians with cardiology over the years in which we have been producing CardiSure. And today we'll be talking about differentiating cardiac from respiratory disease, staging and treatment of canine heart failure, and monitoring heart failure treatment. So there's plenty to talk about, and I'm really looking forward to today's session. Heart failure is caused by heart disease. So heart disease is that umbrella term, and heart failure happens when the heart function is affected so much that either venous pressures increase so severely that fluid accumulates in the lung or a body cavity. So sometimes this is called backward heart failure, and this is also known as congestive heart failure as well. So we can often see it in the lungs, build up also in the body cavities. And we call it right-sided heart failure when the congestion builds up in the heart in the body cavities to produce something like ascites, and left-sided heart failure typically results in pulmonary edema. Now we know that mitral valve disease and dilated cardiomyopathy primarily cause a left-sided congestive heart failure, and that is typically shown as pulmonary edema. So when we think about congestive heart failure, one thing that is quite important is being able to differentiate congestive heart failure from primary respiratory disease. And primary respiratory disease is actually quite common, particularly in these older, smaller breed dogs. We can often see things like chronic bronchitis as well as airway collapse. Now, the reason I'm talking to you about differentiating these two diseases is because it is relatively common, and something that cardiologists report is when a veterinarian refers a patient to them because that patient has not responded as well to the medications as they would like, and they would like a cardiologist to do further workup. But what often happens is that when the cardiologist goes and examines the patient, they actually find out that that patient is more likely to be suffering from primary respiratory disease, and that veterinarian often jump to the conclusion of cardiac disease because that patient had a murmur. So obviously we have advantages of being able to differentiate between the two early on in the disease process so that we are heading down the right road. But it's easy to get the two confused, particularly as our patients don't come in with a label. They do in fact come in with presenting signs. And this is the typical triad of cardiorespiratory presenting signs that an owner may report to you when they first come to your clinic. And one thing that we can ask ourselves when we're thinking about these presenting signs is to consider, is congestive heart failure actually causing these symptoms? And we can think about our presenting signs, and actually if we drill down a little further, we can get quite a bit of information just from the presenting signs before we leap into diagnostic testing and x-rays. We can actually give ourselves a few clues. So looking at the presenting signs that we have, of course, we have exercise intolerance and fatigue. Unfortunately, this is quite a non-specific sign, and there are many, many things, not even just cardio or respiratory, that can cause exercise intolerance or fatigue in older dogs. But what we can look at more specifically is dyspnea, tachypnea, and coughing, and in particular, that relationship between the two. So we know that some patients present with tachypnea, some patients present with coughing, and some patients present with both. And perhaps that relationship can help us guide in one direction or the other between cardiac versus respiratory disease. So let's start with tachypnea. Let's have a look at that symptom and ask ourselves the question, is congestive heart failure causing this symptom? So we know, if we think back to that original definition of congestive heart failure, that the classic respiratory consequence of congestive heart failure is pulmonary edema. And we also know that pulmonary edema always causes tachypnea. Why? Well, of course, we're having fluid accumulating in the lungs, which affects our oxygen exchange. And when the oxygen exchange is effective, tachypnea is the natural physiological consequence. But what's quite useful, and what we can look into the literature for, is some guidance with regards to tachypnea when it comes to ruling in or ruling out congestive heart failure. And this paper referenced at the bottom, talking about sleeping respiratory rates for dogs, gives us some guidance around whether we can rule in or rule out tachypnea as a congestive heart failure as a cause for this clinical sign. So this is a very simple but quite effective rule that we can use as a general guidance to help us in the direction of cardiac versus respiratory. And we can identify that if our patient has a sleeping respiratory rate of less than 25 breaths per minute, we can likely rule out left-sided congestive heart failure as a cause of the clinical signs. So that's a sleeping respiratory rate. We know that in our clinics, our patients likely have a faster respiratory rate because either they're exercising or they're a bit anxious. But equally, we can apply this rule if they have a relatively low resting respiratory rate in our consult room, say less than 25, we can pretty much be sure that congestive heart failure is not causing those clinical signs. Equally, on the reverse, this paper also mentions that if dogs have a repeated or consistently elevated sleeping respiratory rate over 30 breaths per minute, it might warrant additional investigation to determine whether it's congestive heart failure or respiratory disease that is present. So we can use the presence of tachypnea to rule in congestive heart failure and the absence of tachypnea to rule out congestive heart failure. So we can move on to our other symptom, which is coughing, and we can ask ourselves, is congestive heart failure causing this symptom of coughing? And again, if we think back to our original definition of congestive heart failure and the main respiratory consequence of congestive heart failure being pulmonary edema, so classically, the presence of pulmonary edema does not cause coughing, only when the pulmonary edema is very fulminant, so there's a lot of liquid in those lungs. It can sometimes overflow, and you would probably see other symptoms associated with that, such as blood-tinged sputum as well. So what we can tell ourselves is that coughing actually has quite a low specificity for heart disease. It's not necessarily tied into pulmonary edema in the way that tachypnea is. And this paper is very interesting for anyone that wants to read a bit more about this concept of a cardiac cough and a bit more about the evidence behind whether coughing is really associated with congestive heart failure. I highly recommend this paper here. But in general, it concludes that coughing has very low specificity for heart disease, and we shouldn't rely on it as a clinical sign to diagnose heart disease or heart failure. So the best thing to do if you're seeing a patient who has got perhaps that triad or is an older patient who has got a cough is to ask yourself, does that patient have tachypnea? And that can help guide you towards the cardiac disease or away from cardiac disease. So my snappy title for this slide is Thinking Cardiac, Check for Tachypnea. And we know from this paper that an increased respiratory rate is the most reliable independent predictor of congestive heart failure in dogs, whilst coughing without tachypnea or dyspnea is much more likely to be a primary respiratory disease in origin. And that's even if they've got perhaps a quiet heart murmur as well. So we can rule in the concept of congestive heart failure with tachypnea. So we can have cardiac or respiratory with tachypnea. But if we have coughing on its own, it's more likely to be respiratory only. So that's the first kind of useful little tip. Have a bit of a drill down into your presenting signs to help guide you towards which route to take. Next, we have our clinical exam. Of course, we don't have to work simply on our presenting signs. We can also look at the clinical signs. And I hope some of you have a pen and paper to hand, or you're sat down with a pen and paper. And if you do, please, you can draw a line down the middle of your pen and paper, down the middle of your paper. On the left side, you can put congestive heart failure, and on the right side, you can put respiratory disease, because we have a little interactive exercise to do today. So what I'll do is I'll give us a clinical sign, for example, pale mucous membranes, and it's up to you to decide whether this clinical sign is more likely associated with heart failure or more likely associated with respiratory disease. And it's up to you to write it down in the column that you believe is correct. Of course, if you don't have pen and paper, please just do this mentally, but take a moment and consider the clinical sign. So for pale mucous membranes, as our example, we can decide whether that's more likely congestive heart failure or respiratory disease. And don't worry, I will give you the answer. And in this circumstance, pale mucous membranes is typically associated with congestive heart failure. And this is perhaps also more evident when that patient's been doing a bit of exercise as well. So if you perhaps take them for a short walk or move them around the consult room, and then examine the lips and gums, don't look at the tongue, it won't be very helpful, but the lips, gums and ocular membranes, if they go pale after some exercise, this can be a sign of congestive heart failure. And the reasoning, if we think back to your physiology, is quite obvious. When our mucous membranes are pale, we're having quite poor tissue perfusion, and the heart as a pump is not working effectively. What about a clinical sign of cyanosis? Do we think this is more associated with congestive heart failure or respiratory disease? I'm giving you a moment to think about it. I'll give you 5 more seconds. Make your decision. So cyanosis is typically more associated with respiratory disease than congestive heart failure, and that's because the blood is moving around the body, but it doesn't necessarily get that opportunity to be oxygenated. So our heart is working as a pump, but our lungs aren't working effectively at that oxygen exchange. Our next one is jugular distension. So do we think it's congestive heart failure or respiratory disease? And this one is fairly obvious because of what we spoke about, perhaps that increase in venous pressure. So jugular distension is classically associated with congestive heart failure. What about inspiratory crackles? If we hear inspiratory crackles on our patient, do you think it's more likely associated with congestive heart failure or respiratory disease? Give you another couple of seconds to decide. So inspiratory crackles sit with respiratory disease, and I will explain that in a moment. Our next one is expiratory wheeze. Does this sit with respiratory disease or congestive heart failure? So expiratory wheeze also sits with respiratory disease as well. So it's really rare to hear crackles when we have pulmonary edema, unless it's a very extreme pulmonary edema, where we classically would see fluid dripping from the nose or the mouth. Inspiratory crackles are often associated with the reopening of small airways that have collapsed after expiration, and an expiratory wheeze, which is the narrowing of these small airways as the patient breathes out. These are very common in lower airway disease. So again, they sit more associated with respiratory disease than with pulmonary edema. And our next one is the gallop sound. I'll give you a couple of seconds to decide which side that sits. So our gallop sound sits with congestive heart failure. And that's obvious because that's an abnormal heart sound. So we've got some heart disease present. An increased apex beat. And the increased apex beat, of course, also sits alongside congestive heart failure. What about a sinus arrhythmia? Would this be with a congestive heart failure patient or with a respiratory disease patient? So sinus arrhythmia does sit more with respiratory disease, particularly if we've got some respiratory obstruction, we can get an exaggerated sinus arrhythmia. So that's one to note because often I think we overlook that as quite normal, but classically with congestive heart failure, we wouldn't see a sinus arrhythmia. What about a sinus tachycardia? So sinus tachycardia sits with congestive heart failure. So a failing heart is often a fast heart. And our final one is ascites. This one is a little bit easy. Do you think it sits with congestive heart failure or respiratory disease? So ascites sits with congestive heart failure. It's that body cavity filling with fluid. We have the additional piece of information here that if the ascites is due to right-sided congestive heart failure, you should also see jugular distension because, of course, it is that increased venous pressure. And on abdominal ultrasound, you might see an enlarged vena cava and hepatic venous congestion as well. If you were to sample the ascites, the specific gravity of the fluid would be between 1018 and 1036. So here is a slightly neater version of that slide. Take a picture, save the list, and then you can mark your answers later to see how you did. Now, it might seem a little basic again, but I do think it is really helpful to have that kind of problem-solving approach. Now, when you have a patient, you can write down their clinical signs and then try and sort them into one camp or another. At least this practice asks you, what do you think of Chi-Chi? Do you think congestive heart failure is the cause of Chi-Chi's symptoms, knowing what we know from what we've discussed? I'll give you a moment to vote.
Hi, Felicity. I'm getting some answers here. One, he's saying yes.
Okay.
Very unlikely. No. Yes.
It's difficult to get agreement, isn't it?
Yeah.
It looks like the majority of people are going for very unlikely, which is the correct answer. So as we discussed, with a respiratory rate of less than 25, even in the consult room, that makes congestive heart failure very unlikely to be the cause of Chi-Chi's symptoms. Additionally, there was no reports of breathlessness by the owner, so our presenting sign made it quite unlikely as well. And her heart murmur was quiet. So it made, again, very unlikely that congestive heart failure is the cause of Chi-Chi's symptoms. And what we probably want to do is look at doing a workup on respiratory disease for Chi-Chi. So well done, 80% got it correct. Our next one is Bonbon. Bonbon is an 11-year-old male muted Bichon Frise. And the owner has reported that Bonbon has been coughing and is also less willing to exercise. Bonbon becomes breathless when out on walks. And on thoracic auscultation, you find that he's got a loud murmur. Respiratory rate in consult is 44. And when Bonbon walks around the consult room, his gums become quite pale. You notice that as a clinical sign. So again, we're asking the question, is congestive heart failure causing Bonbon's symptoms? So I'll leave those up for a couple of seconds so that you can digest them, and then I'll move on to the question where you can answer.
Hi, Felicity again. I have
Hi.
3 answers, 3 saying yes.
For Bonbon? Okay.
Yeah.
Perfect. So that's through the question answer. We can also answer on the Slido.
Yeah.
So if we scan the QR code. Good.
Oh, 4 yes, 1 very likely.
Excellent. I didn't put yes because, of course, we need to do a few more tests. But yes, and very likely, I think they're interchangeable, aren't they?
Yeah, 5 yes until now.
Good. Looks like the majority of you have got this one correct. Absolutely. So we've got that loud heart murmur, we've got that pallor on exertion, and we've got that elevated respiratory rate as well, all of which indicating congestive heart failure for Bonbon. So well done to the 95%. So let's move on and talk about diagnosis, because if Bonbon, we're suspicious, has congestive heart failure, what we want to do is perhaps some tests to confirm this. So another question for yourselves. What diagnostic test do you classically use for congestive heart failure? Combination, X-ray, echo, or proBNP? Amazing. Okay, thank you very much for your votes. It looks like echocardiography is winning when it comes to diagnostic tests. Dr. Ahmed, you've come on camera.
Yeah, I have 2 echo and 2 combination for answers.
Absolutely. I think my favorite would probably also be combination. I think echocardiography is useful when it comes to diagnosing congestive heart failure. We also need to check the lungs for pulmonary edema or check the abdomen for any congestion. Let's dive into it a little bit deeper. So the diagnostic tests that I've listed here, proBNP, is quite useful. It's a blood test and it has a sensitivity of around 85% and specificity of 81%. So perhaps we could use this just to rule in, rule out some cases. Thoracic radiography is what cardiologists still recommend as the best test for congestive heart failure. So to assess the lungs, to look at pulmonary edema. And it's always recommended to do it inspiratory time so that you have the best view of the lungs. Always do 2 views, this is essential, and be really careful to avoid motion blur. It can be very challenging to get some good thoracic radiographs. The best thing to do is to ensure that you're looking for left atrial enlargement before you go looking for congestive heart failure, because I think it can be quite easy to mistake other patterns or perhaps just having quite a fat dog as pulmonary edema. So looking at the size of the left atrium can help guide you If you've got a normal sized left atrium, but you have a respiratory pattern, perhaps you're looking more at respiratory disease again. And with echocardiography, this is the best test if you've got a heart murmur and you want to understand what's going on in the heart. You want to check, for example, mitral valve disease or mitral regurgitation. And this tends to be the best test to look at the heart, but it doesn't necessarily define congestive heart failure, because congestive heart failure, we're looking for that fluid accumulation either on the lungs or the abdomen. In general, you need to look for a dilated left atrium, and the cardiologist Dave Dixon, he recommends kind of just eyeballing the left atrium. And if it doesn't look that big, then the dog is probably not in congestive heart failure. The one exception to that rule, of course, is that if there is an acute leak with a mitral valve, such as a ruptured chorda tendae, then the left atrium doesn't actually have time to enlarge. But in chronic mitral regurgitation, the size of the left atrium accurately reflects the severity of the disease. And when it comes to thoracic radiographs, we have produced a poster to make it a little bit easier to interpret thoracic radiographs and to do a vertebral heart score or a vertebral left atrium score. So at Dechra, we recognise that there are many a challenging case, and if we can provide a little bit of guidance in those moments of need, we can. And if you would like one of these posters, please get in contact with the veterinary group. So once you've diagnosed congestive heart failure, it's also recommended that you do some baseline tests after that. So the baseline tests that are recommended are to do a hematology to check for anemia, which is relatively common as a concurrent consequence of congestive heart failure. Biochemistry to assess urea, creatinine, and electrolytes. If you are planning on starting a diuretic, which is the fundamental treatment for congestive heart failure, it's important to assess your patient's hydration status, and with that, their kidney function as well. So urinalysis to complement the biochemistry to assess your kidney function. And electrolytes are helpful if you're using furosemide to be sure that your potassium is within the normal range before you start. It's also recommended to do blood pressure measurement to rule out any concurrent systemic hypertension. So some take-home tips on diagnosis is that mitral valve disease and dilated cardiomyopathy primarily cause congestive heart failure of the left side of the heart, which results in pulmonary edema. Coughing without tachypnea is more likely to be a respiratory disease. Crackles and wheezes are more often due to airway disease than edema. And small breed dogs with symptoms, if it is heart failure causing their symptoms, their murmur should be louder than grade 3. And if your symptoms are due to heart disease, there should be a large left atrium on the echo or the X-ray of any. So I'll stop sharing my screen. And just say thank you to you all for listening.